I guess that means I should get started. Okay. You guys ready back there? Thumbs up. Awesome. Good morning. I am Steve Posnack. I am the Deputy National Coordinator for Health IT. Thanks. I didn't even have to say wait for applause. Thank you for being here. This is the third Interoperability Forum. We're excited to have you. It's bigger and better. The trilogy is now complete here at this point. Full, audience. We appreciate everyone signing up. We got as many people in as we could. We have a lot of folks on the webcast as well, which will be available for the plenary sessions both today and tomorrow. I want to thank Stacy and Lolita from our team at ONC who put all of this together, as well as the rest of the ONC team. We had some pre-forum workshops yesterday, a lot of logistics, as all of you know from doing your own events and participating in events like this. So everything will go seamlessly. We had fire alarms yesterday, so hopefully we got that out of the building system, and hopefully we won't have any of that today. I want to thank Don for his confidence in me in this new role. We had a small going away ceremony for John White at the office, and I know he's out there watching us. Literally. On the webcast, my team gave his seat away as soon as they found out that he was leaving ONC. So one of you are sitting in the commemorative John White seat now, and be thankful. This year's forum is a bit later than last year, and for those of you that know, when I have an opportunity to give kind of general opening remarks, I look for some industry context that can help us set the stage. Because it's a little bit later in August, the thing that many of us may remember, a few days from now, a storm forms in the Gulf. And that storm next week would be called Katrina. And then there was the healthcare response to that. 14 years ago, we did not have the same infrastructure that we do today, thanks in part to your efforts, to our efforts collectively together. But it did set in motion what the power of collaboration at the Department of Health and Human Services could do with the private sector. We worked on katrinahealth.org, if those of you that remember that, on a medication-related focus project. And I know many of you probably either reinvigorated or started your careers in health IT because of an event like that. And it's always something that I remember when August comes around. I know we are all very busy. The forum is an opportunity for us to come up for air, to take stock in what's changed in the past year. We have certainly kept you all very busy. We've had a proposed rulemaking. We've had another round of the Trusted Exchange Framework and Common Agreement, among other requests for public comment. You have now made us very busy with thousands of pages of comments to read through, which we certainly appreciate. And when we talk about interoperability, and we use that word as in our tech speak, what we really mean and why we're at this all together is about improving experience for patients so that they can get their data on their smartphones, not so far-fetched anymore compared to 14 years ago. They can shop for care in a more seamless manner in the ecosystem in which we live, for providers to improve the way that they use technology and to supercharge their care coordination capabilities. For caregivers, for public health, for pharmacists, for researchers, for payers, I could go on and on for all of you else out there that I didn't get to mention as part of that list. We are here to make those changes and talk about interoperability in a way that's going to improve the experience that we have together in the healthcare system. So I have a few other logistic notes, since that I've kind of covered my opening remarks to help get you hyped up for all of our plenary sessions today. The recording of the plenary sessions will be made available. Slides will be posted on healthit.gov. We are at capacity, so make sure that you're finding seats that will help enable most people to get a seat of their choice. Two most important things, coffee and Wi-Fi. We have coffee out here this morning, but it'll only be available this morning until it's basically used up. You'll be on your own for the afternoon, I guess is the bottom line. Wi-Fi information, capital ONC 2019, if you need access to the Wi-Fi. Let's see what else. Hashtag on Twitter, hashtag Interop Forum. We have over 700 people that were registered for in-person, which is great. Highly exceeding our in-person attendance from last year. We obviously have a new venue. Hopefully you'll give us some feedback if you like this venue better. We may actually have to get more space for next year in terms of the workshops and other types of track sessions that we provided. Other logistics, last year we had a little post-it note game that we called Shout Crazy Cool. That has made a reprise. It's out there for you to identify things that you want to give a shout out to, something that's still crazy in 2019. Last year's didn't change, that we still have a fax machine, powering healthcare. If there are things that are cool that you want to see in the future, you can certainly identify those, and the reward will be that we will try to pick the post-its that resonate the most with us, and I'll talk a little bit about them in the next day. At the registration desk, I would encourage you, or next to it, outside over there, we'll have some booths set up for your interest. I would encourage you to check out the various topics that will be covered there. And then for lunch, you are on your own. We're right near Chinatown, so there's plenty of food and other options for you to find, and just make sure that you're back in time to attend the track sessions. Without further ado, I'd like to call up Dr. Rucker, our national coordinator, for some opening remarks.
All right. I would like to add my welcome on behalf of ONC. It's great to see everybody here. I have to say, I never dreamed that I'd be part of anything like this. Thinking about interoperability, I remember my incredible excitement as a grad student at Stanford when I got a 2400 baud modem and could then, at midnight, when the network had enough speed, ship in my computer science homeworks. So today we have a very different computing world. We have a world where we have, back in the 80s, we didn't have the computing power, we didn't have the bandwidth, and we certainly didn't have the data. Today, when we look, we have all of those things, obviously the data, and I know it's been sort of a bit of a tortured path, but we have EMRs pretty much everywhere now, thanks to the work of, frankly, ONC and my predecessors as national coordinator. So we're in a very, very different spot, and we are riding a global wave of computer science that is transforming every industry, and it will increasingly transform healthcare. The other big wave that I think sort of fuels interoperability, because ultimately interoperability is really about the economics of healthcare and affordability. The other big wave that's fueling this is the very complicated consumerization of healthcare. We've had a healthcare system over the last 50 years, which has been a very third-party payer-driven system, right? And so we know the types of things that have grown up to feed those mechanisms, whether it's quality measures or prior authorization or PBMs, and there are literally dozens and dozens more of things that are really not consumer-facing, frankly. They're really about the mechanics of third-party payment. As the costs rise because of these rather uncontrolled mechanisms, we're by force having to bring consumers and consumer choice back in. And when you look at consumers and healthcare, we know it's quite a problematic issue. Consumers don't really have the knowledge of healthcare, the consumer knowledge of healthcare that we have about every other complicated decision in our lives. And as consumers, we're essentially forced to shop often from delivery system configurations that are very inward looking. So they're not really about interoperability. They're about referring within the system, if you will, preventing the so-called leakage. I think I've been at staff meetings on the provider side where that's been a discussion. And so we have this collision of the consumer economic world and the computational world at the heart of that collision, right? At the grinding edge, maybe lubricated, maybe not, sometimes lubricated, are application programming interfaces, APIs, right? How do these computers talk to each other to facilitate the conversations that are driven by the public's need here? That fundamental realignment based on APIs has transformed our financial industries. It's transformed our travel industries. It's transformed our printing, entertainment industries, right? Into totally different things. And we think this is happening in healthcare. In 2016, Congress, at the very end of the year, President Obama and the Congress almost unanimously passed the 21st Century Cures Act. A lot of that dealt with modernizing the FDA, but there was a big section in there in Title IV where Congress really said we want to have the public empowered and on their smartphones, and to have these APIs that fuel this transformation be without special effort. And in case folks didn't get the message, Congress also said the baseline assumption is that information will flow, that information blocking is prohibited, as pretty much everybody here, I believe, knows. You can go to healthit.gov if you have questions in our proposed rule. We have a number of exceptions to operationalize the concepts of information blocking while being very, very, very sensitive to issues around privacy, security, harm, performance. But the Cures Act paints, I think, the groundwork for a different world. That was done with President Obama. I can absolutely assure you that President Trump, the White House, Secretary Azar, are all very interested in working on this. We have Will Brady, who's the Assistant Deputy Secretary for the department here this morning. If you have any questions, you can ask him. He didn't ask me to say that. But kidding aside, we are very, very serious collectively. You've seen the CMS rule as well in getting the American public to have the benefits of interoperability on their smartphone. And what are those benefits? What is that world that we see from the work that all of you here in this room and all of you who are watching on our, on the internet? What is that world that we hope? Well, I think first we start with some of the basic things. Let's make the electronic medical record a more powerful, understandable, and actionable thing. It's largely been a billing tool, but we're trying to make it so it really does automation. We've worked very strongly together, our clinical team, Andy Gettinger, Tom Mason, with our colleagues at CMS, a lot of folks at CMS, to rethink the physician notes so that they actually have more information in them rather than serving as a billing marker. A lot of work there, more work to come. We anticipate in this app economy that some folks will get very much into specific diseases, specific illnesses. At Datapalooza this year, there was a young woman who built her own website. She had cystic fibrosis, and because her mutation didn't have a targeted therapy, she built a website and put her entire DNA sequence on in the hopes of getting a cure for herself. And this is the type of, I think, out-of-the-box use that we're going to see over time as people figure out how that they can change their healthcare with these apps, and what we've had afforded by Congress. I think the biggest tool, frankly, the American public, if there's anything we do well, it is shop. And we have not, yeah, right, okay, tell me you've never been on Amazon, right? I know. But seriously, we've had no tools to shop. We don't know what the price of things are. We don't know what the product or service is. And I think that price and product transparency, you've seen the executive order on that, is going to be part of what this app economy does for empowerment. It's going to hold us as providers, I think, accountable for levels of service and innovation in a service that we haven't had. I think it'll actually be some amazing opportunities. All of this, Brave New World, is predicated, frankly, on the right of the patient to get their data about their body, right? We have not had that right. We have sort of lived with far less knowledge of our bodies than could be afforded by modern technology and modern science, in spite of the extraordinary efforts and accomplishments of modern science. And in our world of protections, what we're talking about really is predicated on what's called the HIPAA right of access. Just a one-line course in HIPAA. Most of HIPAA, when it's talked about, is actually typically between providers and payers, that world of covered entities and business associates and the treatment payment operations exceptions. This is under what's called HIPAA authorization. What we're talking about is the individual right of access. So that's a very, very, very different beast. In a lot of the political discussions, those things have gotten absolutely convoluted, but they're really very, very separate things. What does that mean electronically? What it means is that under your right of access, under the Cures rule, under our proposed rule, you will have the right to select an app and using the OAuth 2 security protocol, bring it to a provider endpoint and download your data. And so it's important to understand what that means. It means you have to choose the app, you have to bring the app. I know there's been in some of the public comments, we've seen people say, well, apps are just going to just randomly get data. No. There's absolutely nothing that allows that to happen. Consumers have to bring an app one at a time to the providers. For the providers, we're trying to make this a very low burden thing. You stand up a FHIR endpoint, right? So it is a relatively straightforward thing. Many of the major vendors already have FHIR endpoints. We've had great cooperation with most of the vendors. It is what fuels the entire API economy, whether that is Uber or anything else, right? Uber has all of the APIs for your credit card, for traffic, for you as a customer, for the drivers. That world, we're asking providers to send up an endpoint on that, and that's how the data will come. Now, I think we're all very, very mindful that medical data is, I think, different than, say, a banking transaction in that medical data, and if it gets out, is permanent. It's forever, right? If you have, pick your socially ostracized illness, whatever you don't want other folks to know for many number of reasons, once it's out there, we think most patients are actually going to be as protective of their medical information as they are of their banking information. We don't just willy-nilly pick some bank off a truck. We actually go very much for brand names. We think this is going to happen in healthcare, but the markets will decide that. The overall challenge that we deal with, and we've had a number of rewarding discussions with Congress about this and with the White House, are on secondary uses of data. How do we do consent? What's appropriate? How are the public notified? I think we all realize that these end-user licensing agreements we click through at the speed of summer lightning. For any of you who were yesterday and got inundated, all right, summer lightning. They don't really work in this modern world. It's a global problem. The GDPR, the California Consumer Protection Act, I think we're coming together on that. We're working with a number of folks on better ways of doing consent. And there's a very, very complicated, delicate balancing act on how do we protect the consumer's right of access, your right, our right, my right, to know as much about my body that I could take care of it for as long as I possibly can, with protections around privacy. So we're working with folks. There is, as you might imagine, it's Washington, so there's all kinds of discussions about that. There's a collision in some of these discussions with the fact that a lot of people, I think we all understand, have, because of the incentives they've responded to, not surprisingly, have very non-transparent business models. So the swirl of having totally non-transparent business models and how do you inject transparency into that world, the issues of privacy, there are a lot of discussions to be had, and I know many of you have been part of that. Overall, though, look at the big picture. We are in extremely exciting times in healthcare. I have to say it's disappointed me a little that it's taken so long. I naively thought that the EMR problem would be solved in 1991 when I graduated in 1988. So much for my predictive powers. But I do believe that we are actually, that exponential growth is finally coming. You know, good things happen to those who wait. I think we have extraordinary abilities and opportunities to make healthcare efficient. Anybody who has been part of the healthcare delivery system knows we have not used computers to make it efficient. We're the only industry that's used computers to make more work for ourselves. I think that entire worldview is going to change. I want to thank all of you on behalf of ONC. We look forward to working with you and working with you, whether that is on the individual, consumer-controlled, secure APIs that is the focus of many of our sessions now, whether that is with the Trusted Exchange Framework and the Common Agreement, whether that is some of the things that we've done in the past, the direct exchange. I just want to shout out to the direct folks. 1 billion messages have now been passed using the direct exchange. So just to give you a sense, again, you know, it's taken a while, but very, very powerful. We're doing some exciting things in population health, trying to make that. The population health work you may have heard of as either population level data, bulk data, the Da Vinci group, the FAST project, so the, you know, rapid acceleration of FHIR. All of that, just by way of HIPAA contrast, is under current HIPAA. So any of those things are not some kind of on-demand thing. Those things require a signed contract, service level agreements. They're just as if you did any other data download under HIPAA. Those things all, what we're trying to do there is just make it more computationally efficient for folks to actually have big data, right? You can't have modern computing, AI, machine learning without big data. And so far, we haven't really had the infrastructure to do that. So we're doing that there. Again, I will welcome you for a great conference and your participation. Let me now introduce Elise Anthony. So Elise is head of our policy group. We basically have ONC carved into a technology group, which has been headed by Steve, and Elise heads our policy group. A lot of work with Mike Lipinski and a great team on all of the rule writing. You have given us 2,000 comments. We're plowing through them. A lot of great points, and we look forward to working with you on addressing those issues and working through all of the things you've provided there. With that, let me turn it over to Elise. Thanks.
Well, good morning, everyone. How are you? All right, good start. Okay, so this is not a policy conference, so I don't have too much to say today, other than to really say thank you. Really, my team and I are here to listen, to hear what's happening on the ground from a technology perspective. Steve and I always say that, you know, you can't have technology without policy, and you can't have policy without technology. So our teams work very closely together to get it right. As our 2,000 comments or submissions indicate, you guys have been listening and providing us feedback. So really my goal here today is to give you a little bit of update of some of the things we've been doing for the policy team, but more importantly to sit back and listen. You'll see my team dispersed around many of the different sessions, so feel free to come up to us, tell us what you think, what you're thinking. We always have open ears and we look forward to hearing from you. So with that said, I guess the easiest place to start would be with the rule, because everybody's wondering where the final rule is right now. Okay. So as Don said, we got more than 2,000 submissions, and I have to tell you how excited I am about that, because you guys usually hear me say, my public service announcement, please engage with us, please tell us what you think, and you listened. I mean, the number of comments we got, in addition to who we heard from not only developers and patient trade associations and individual patients. We heard from HIEs, just really across the entire landscape, from providers who want to tell us about how what we are doing can benefit their practice, as well as some of the concerns that we need to be aware of. We read every single comment. So we're in the process, as Don said, of doing just that. My team is hard at work. I've read through so many comments, and it's really illustrative of the complexity of interoperability, of the complexity of what Congress calls access, exchange, and use of health information, electronic health information. So we're thrilled to have those comments. We're going through them, and the process is working. That's exactly what we expect from a notice of proposed rulemaking, is we want to hear what we got right, and we want to hear where you think there might be some opportunities for improvement. So as we move towards the final rule, we'll be thinking about that and putting together a final rule that we really believe will advance interoperability, will advance the ability of providers and patients to have what they need to really support the care spectrum, across the spectrum. So more to come on that. Keep engaged, keep letting us know what you think. The other part I wanted to talk about is TEFCA, the other item that folks want to hear about. So the Trusted Exchange Framework and Common Agreement. Supporting network-to-network exchange is one of the other requirements that Congress asked us to focus on in the Cures Act. And we've made tremendous progress on that front as well. So far, we've released Draft 1 and Draft 2. And Draft 2, which was released, and the comments have come back, and we're going through those as well, provided us an opportunity to update some things. We heard from folks, hey, it would be great if there was a technical framework to support this policy or this governance framework that you are contemplating. So we did just that. We released Draft 2 with a QHIN technical framework that demonstrates how we think the interactions between QHINs can work. That as well is in draft format. It's something that ONC believes in very strongly, that we cannot create this landscape of interoperability by ourselves. So we put things out for draft, we put things out for comment so we can get just that, the feedback in. The other exciting part about TEFCA is the cooperative agreement. So we put an opportunity, a funding announcement out for a cooperative agreement, and we are in the process of reviewing that, and we look forward to awarding that cooperative agreement shortly. The recognized coordinating entity that would be supported through that cooperative agreement would help us bring to life TEFCA. Again, and you'll hear me say this, and you'll probably hear the team say this throughout the day, we can't do it alone. And we know that there are stakeholders out there. There are entities who have been engaged in network-to-network exchange, and that there's been successes in that realm. And TEFCA, as we've designed it, is designed to support and bring that to the next level, to be successful, to see the successes and to see those compound and grow, but also to address some of the gaps that we know exist in network-to-network exchange, whether it's things like the exchange purposes or everyone being on the same page in terms of what is required. And that's what TEFCA is designed to do. So with the recognized coordinating entity hopefully coming online soon, we'll be moving to the next stage of working on the common agreement and getting all of the pieces in place between what we see as what are the minimum required things that absolutely have to be in a cooperative agreement to also what we hear from the industry are also required to operationalize that environment on the day-to-day basis. So more to come on that as well. But that's not all we do in the Office of Policy. So Office of Policy is not only about policy development, which is a critical part of what we do, but we also have to think about where things need to be down the line. What's the next step? So the other part that we're starting to work on now is our update to our strategic plan. And our Federal Health IT strategic plan is not just an ONC plan, it's really what the government overall thinks is necessary to support an interoperable environment. So we have started to work with our federal agency counterparts and partners, everyone from SSA, for example, Social Security Administration, to CMS, to CDC, just completely across the field to think about what's the next stage for the strategic plan and where do we need to be in that environment. One of the other things I want to mention is our Health Information Technology Advisory Council Committee, which is another component of the Cures Act. And Congress asked us to make sure we are updating our previous federal advisory committees to the new HITAC. And the new HITAC has done amazing work in a very short amount of time. And I know many of the HITAC members are here, so I want to say thank you to those who are here and online for all the work that they have done. It is a tremendous amount of work and volunteerism that is attached to this work in terms of coming in town, reviewing documents, giving your input in terms of where we need to be to support the landscape that ONC is trying to help create. Over the last year, the HITAC has had, just on the Cures rule alone, has had 4 task forces. They've provided numerous recommendations on everything from thinking about the definition of electronic health information for information blocking, all the way to thinking about TEFCA and the construct that needs to exist to make that a success. And what we do, we cannot do without the high tech standing with us to provide their comment and their feedback. So many thanks to them for all that they have done and all that they're going to continue to do, because in the fall they start up again. So please engage with that. In terms of public opportunities with the high tech, please also listen into the calls. Every single call that we do at the high tech has a public comment opportunity, and it's a great way for you as an individual or your organization to provide some feedback directly to the high tech about what they are thinking about that could impact your day-to-day lives, because it's important that we get that right. If we're developing policy, at our level, and we're not thinking about the impact it has on your day-to-day lives as a provider, as a patient, as a developer, as a HIE, wherever you are in the stakeholder landscape, then we are not getting it right. We've got to make sure that we are hearing what you're saying and we understand the day-to-day impact of what we're doing. And that's where success happens, and that's what we're committed to. So please make sure you're engaged with us. You can see tons of information. I'll give a plug from our public affairs group to our website, healthit.gov. Check there out, sign up for our listserv, and you can see other opportunities to engage with us. I will also say we're also hard at work on thinking about patient access, as Don said, and supporting the education that is important in that landscape. So we work with the Office of Civil Rights in support of that. So we're excited about things like the Get It, Check It, Use It resource, which is online now, that provides a great way for patients to understand and see how they can use their information, how they can get their information, and even how they can update their information with their providers. So check that out. It's a great resource as well. And the other part I would say is we are also thinking about the landscape holistically. So one of my teams works day to day with states, and it's an important part of the interoperability landscape. If we want to think about interoperability and it being successful, it's not just in the federal programs, as we all know. It's thinking about at the state level. So working with state innovation models, working with CMMI, for example, at CMS, working with the states to provide technical assistance on what health IT can do to benefit care and benefit what they need at the state level is critical. So we're really excited about that work continuing. If there are states here, come find me. I'd love to talk to you a little bit more. But overall, as you can see, we've been extremely busy, and we will continue to be extremely busy. And that's exciting to me because it means that we are doing something right. We are engaging with the public. We are understanding and hopefully adding to the landscape of interoperability and supporting innovation in that landscape, particularly around the ability for us to use APIs to support an API ecosystem where information is available on the phone. I always say this to my team: we are all patients. We all have had to do camp forms. We've all had to do submit information on immunization records. We've all had to fill out, or as I will tell you from last week, had to send in a fax copy of a document I sent in 3 times already, but that's another story. Needless to say, we've all been in that position. So it's a heartache that we all understand and something we're all devoted to trying to address. So with that, I want to thank you for all you've done in terms of engaging with us, and please continue to do so. Have a great day.
Yes, thank you very much, Elise. And I want to give a shout out to Elise and her team. In all of this, we are also very mindful of the policy burdens and unintended consequences. So a lot of work goes into minimizing that I think you don't see externally, but that is actually a large amount of work effort. And I would definitely want to second the thanks to the high tech. I think we've overworked them, but thanks to folks on high tech, it's very helpful. We have a wonderful keynote speaker. I first met this gentleman as part of ONC and HHS's work with the Global Digital Health Partnership. And heard, just some of the amazing IT things going on in England, both, in the regions and nationally using a modern IT stack. And so I thought this would be a very, very interesting thing for us to hear and think about. So it is going to be my pleasure to introduce Simon Eccles. So Simon is an emergency department physician from London. Simon is the Chief Clinical Information Officer for the National Health Service for all of England. So that means, among other things, he manages all of the local chief clinical information officers, all of the CIOs of England. He is the deputy executive of a $1 billion per year NHSX digital transformation project that I'm guessing he's going to talk about. And I would just say, which will be obvious to you in a second, Simon is the epitome of English cool. His spare time, he runs and restores classic cars. He can maybe show you his picture of his Bentleys he's working on from nuts and bolts ground up restoration in his Rover. So Simon Eccles from England. Thank you, Simon.
Yes, hard to know how to top that introduction, but thank you very much. It is a huge pleasure to be back in Washington. I first came here now about 25 years ago as a senior medical student doing an elective at the MedStar unit, and I was back up there yesterday. Amazing to see how much it's changed, but I spent a very happy 3 months in Washington. You continue to have some of the most amazing weather of a capital city. I joined Don at a restaurant walking just 2 blocks from my hotel in what I suspect Washington residents would describe as a light shower. I was busy looking for large wooden ships and nervous that the animals were forming into pairs. I got staggeringly wet by the time we got to the restaurant. Can I say a big thank you to Don, to the whole of the ONC, and to the Department of Health and Human Service for inviting me. It's a huge pleasure and a privilege to be here. I hope I live up to that introduction. Many of you will understand the National Health Service, but let me just give you a moment about it. This is England's single-payer healthcare system. It covers the whole population with ubiquitous cover from cradle to grave. We have about 250 semi-autonomous large hospital units, by which I mean they have over 500 beds. They offer a full range of care. They see between 300 and 500 people a day through their emergency departments. We have some 5,000 general practices or family clinics operating our primary care network, covering the whole population as their first point of care. Digitally, we have a range of EMRs, many of which would be entirely familiar to you, some of which are homegrown in the UK, some of which are knitted together from local systems, but we also have Cerner, we have Allscripts, and of course for the wealthy, we have Epic. I'm very conscious that this is also going out on web and publicly, and they are an excellent system, but never knowingly undercharged. We have a range of community system providers, and we have a range of primary care system providers. And I think it's fair to say that they haven't always joined together as best we like. I'm just trying to find my clicker because I need to give you a slide or two in a minute. The example that we use every time for that is oncology. And virtually any British citizen who's been diagnosed with cancer or is caring for a relative who's been diagnosed with cancer will explain to you the frustration of their path through the system. The care is excellent. The care is seamlessly joined up, and we have really quite tight waiting times now for patients with cancer. They get through the system okay. But their family practitioner, their community nurse, charity sector support, their local hospital, the tertiary referral oncology centre, and in many cases, quaternary referral for some of the treatments that are only offered at limited numbers of centres, just don't join up. And for me as an emergency physician, it's seeing those patients at the most emotionally traumatic points in their lives, clutching sheaves of paper because that's the way they can guarantee I understand what's going on with them. We have not served them well, and we need to do much better. So we are NHSX. We're not entirely virtual reality, by the way, but I'm not responsible for the pictures. NHSX was formed out of our Secretary of State for Health, our cabinet minister's frustration at the number of bodies working within this sector, government bodies, that weren't entirely joined up. And he said, right, you lot, pushing you together into a single organization, $1 billion a year budget, you are responsible for digitizing the health service completely. This is the third time I have stood on stage over a decade promising to digitize the health service, but this time we mean it. We are pushing very carefully a different methodology about how we go about this. So for me, it centers on the user need. And that user need may be the citizen I was just describing with cancer. It may well be me as an emergency physician or any of my colleagues in nursing, allied health professions and elsewhere who need to best care for the patient in front of them, but end their frustration at endless drop-down menus and continuous use of the right mouse click to the point that we wear mice out at a frenetic rate. It's about privacy and security. Unless we can retain trust, not just citizens' trust. Interestingly, that is not our biggest challenge. Our biggest challenge is retaining clinicians' trust on behalf of the citizens they care for, that we're going to treat their data responsibly and we're going to get this right. We need interoperability and openness, and I was very interested in Don's points about APIs, and I'm going to come on to a lot of this. And lastly, it's about inclusion. Digital doesn't work for everybody. We traditionally talk about an age divide, and I think that's wrong, actually. Silver surfers are a huge portion of the UK population. They're there with their iPads, and it's all you can do to crowbar them off them, frankly. But we do have a significant proportion of our population who are disenfranchised by a demand to go digitally. What we're intending, and we're working hard at, is by moving more and more citizens' care to a digital-first environment and allowing them to close their episode of care digitally, by email, by advice, whatever it may be. We're providing more face-to-face time for those for whom only face-to-face will really work well. We also have a drive, not represented on here, around transparency. So again, I would absolutely echo Don's point, though I appreciate the transparency is even harder in the US system than it is in the UK. But transparency of quality, of outcomes, that data is available, interestingly, in the health service, but it's not always available to the citizen. And how do we ensure that anybody, my mother-in-law needing a knee replacement, has access to the same quality of information about the individual unit she may be going to, down to the individual surgeon, and we now have that information available. We're trying to make sure that is accessible to the public in a meaningful and understandable way, because that drives choice and it drives improvements in quality. What we've seen, partly in the NHS, but particularly interestingly in Germany, we're one of the first to do this, by making that quality information publicly available. It wasn't public choice that drove a really significant improvement in quality. It was interprofessional rivalry between those orthopedic surgeons or cardiothoracic surgeons or elsewhere. And believe me, there is nothing as competitive as a cardiothoracic surgeon. As possibly plastic surgeon. There are many jokes I can let in here, and I won't in a public setting, but ask me later. But what they saw was if they plotted the outcomes on a sort of standard graph with a box and whisker plot of one standard deviation and two standard deviations, those whiskers outlying negatively just disappeared. Nobody wanted to be a negative outlier, and they worked really hard to ensure they weren't. Then the size of the one standard deviation reduced. This took about 3 years, and then overall quality improved as everybody aimed for the best. I'm also interested in how we approach that quality data. So we put enormous effort into gaining quality data from our organizations, and it imposes a significant burden. I'd echo points made earlier about the burden of collection onto our clinical communities. We also ask patients for their feedback on the quality of care they've received and their perception of its quality, which is a different thing, but still matters to us. But again, it's a burden. I put it to you that social media can give us really interesting insights on the quality of our organizations, and often much, much faster than our traditional collection tools, which by the time they've been through a governance process are a year out of date. So, change of plan, we're moving to NHS X, a different approach to how we interoperate healthcare data. We're a mission-led organization, and echoing Don's point, our first mission is to reduce the burden on staff. And that is a punchy move in an environment in which traditionally everybody's first mission is about improving care for patients. We've said actually we've got real clarity on that journey. Our problem is that staff do not enjoy using the information technology tools available to them. And equally true in the US than the UK, everybody is on their smartphone, particularly on any sort of public transport or airport arena. They're all glued to their phones. It's all you can do to crowbar people off them, as I mentioned earlier. But you go into a healthcare setting, and our clinical community reluctantly are drawn towards the computer on wheels or the fixed desktop, not because they wish to interact with it, but because they have to. How do we change that way of working so that that same pleasure one derives from tools you don't have to use on your smartphone is available as a means of data capture to our clinical staff? So that's our first. And there are good tools, and many of you will have recommendations, and we want to hear them. The second is to empower citizens. We're absolutely clear, if we give citizens access to the information on the care they should receive for any given condition, their care plan, and they feel that that care plan has been co-produced with their physician, they are much more likely to receive the intended care at the appropriate time points, and in turn they're likely to get better outcomes. One of our most dramatic examples of this is in the field of vaccination. That people are not brilliant at following vaccination schedules. There's been a lot of social media around vaccinations, and can I issue a public apology on behalf of Great Britain that you now have Andrew Wakefield, but you're welcome to keep him. Anyway, I can't say anything else because I will almost certainly get sued. But we do have a challenge around vaccination. Interestingly, where we put vaccination schedules into the hands of parents, we give them absolute clarity, and we make it really easy for them using their digital device to obtain vaccination wherever they may be contacting care. We see those rates improve, and we have more work to do there. Clinical information safely and digitally accessed. So we record huge volumes of healthcare information about every interaction we have with patients, as do you. But it's often boilerplate text. It's screeds long, and it isn't easily transported from one place to another. It may arrive as a PDF. We're pretty good at health information exchanges, but that means you've got to read the whole thing. It is not freely interchangeable coded information, and that needs to get better. I'll come on to some specific examples in a little while, but that's our big change. And our previous approach to interoperability, and this is the bulk of the talk in a moment, was that we bought it centrally. I was the National Medical Director for the National Programme for Information Technology, for which I have to apologise in the UK, but not here. We spent $12.5 billion on healthcare technology, which for England is a large sum. So it's a rough multiply by 6 to get a US equivalent. That's a pretty punchy sum. That didn't give us interoperability. It gave us a lot of systems, but it didn't join them together. And we're now moving much more to an era of interoperability standards. And we need to derive the smallest number of standards. Every standard imposes a burden, but that those standards are really meaningful and work. And then we use the large levers, which essentially say we won't pay for care unless you've transmitted the information against an interoperability standard. And we want APIs that allow the brilliant app developer market we can see to innovate in a way that we can't at the center. And to give you one example of that on that information and the citizen empowerment, I was looking at two systems about 6 weeks ago for maternity care. One was a Southern England-wide system produced by Wessex healthcare, which is a large area covering a population of about 3 million people. And they've put together an absolutely lovely, standard, public sector derived app for women, for parents to manage maternity. And you track through it, and it contained everything you'd expect in exactly the way you'd expect. And then the next presentation on was private sector from a vendor of maternity systems who had also derived a patient-facing application, and it was gorgeous. It was beautiful. It was a joy to use. It was worth getting pregnant for. And it pulled together phenomenally good NHS-derived, completely assured content on what you needed to know at each stage of the pregnancy, what more you might want to know about blood pressure, if you've been told any words during a consultation that didn't make sense, how to look them up, and what more. It was lovely. And the public sector isn't good at getting things that brilliant. Interestingly, we see a huge amount of innovation from our charity sector, wanting to make sure that diabetic patients, cardiovascular patients, premature baby patients, a subject very dear to my heart, all get the best information they can to drive towards prevention and so on. And we're using that. We have a real drive in sepsis at the moment. Which leads me to that fourth mission: how do we improve safety across the NHS? And here, data is king. The more data we have about where errors occur, unexpected patterns of behavior, where people aren't following guidelines and protocols, in many cases from ignorance rather than deliberate variance, we can help them and technology can help them. And I envisage a world, not yet present, in which, as I practice as an emergency physician, all too infrequently, sadly, I have the equivalent of the finest resident I've ever come across, sitting on my shoulder, whispering into my ear that perhaps I may be out of date on this, and that the pathway, the protocol has moved on, the dosage has changed. And because they're electronic, I can't shut them up or intimidate them. They will just continue to give me excellent advice and guidance. And that takes me to the last one, which is productivity. As Don mentioned, and I would completely back, indeed I've already tweeted, we are the last sector that has not really seen a significant technological gain in productivity through technology and standardization. And every other industry has. There are some amazing slides. I was at Sci Business School about 4 months ago, and they had a fantastic slide, which sadly I haven't been able to steal, but there's still time, on productivity gained by industry from standardization and technology. The biggest is agriculture. Numbers of people on the land 100 years ago to now is just phenomenal. Shipping was second, to my slight surprise. The number of people required to load and unload ships to now where it's almost fully automated. And then right out on the other side of the graph, there were just two of us: construction industry and healthcare. And construction industry is learning to standardize and is using technology. We're sort of on our own. So we've got a job to do here. Major retailers, all of them, have been automating and using artificial intelligence, machine learning, for demand prediction and workforce levels for 20 years. And in my health service, I don't know if it's true in your organizations, every week we are slightly surprised by Monday. And once a year, we find that it gets cold and winter comes along and patients get sick. We have work to do here. So these are my 7 key priorities as the National Chief Clinical Information Officer. The things we should standardize as the basic building blocks to enable the healthcare system to work. Do photograph slides for those who are, but they will be made available, I'm confidently assured, and they have been through the most thorough vetting process to make sure I haven't got it. But CCIO 7. So first amongst them is the citizen identity. This sounds blindingly obvious, but I know you face similar challenges. We do have a national identifier for health service, and that is separate from identifiers for any other means, which is really quite important when not everybody is entitled to all services offered by the state, but they are, in our case, entitled to emergency care and maternity care, and they get them free at the point of use. So we want to have our own identifier, one that people are not afraid to use. But that needs to be attached as metadata to every piece of information we capture about that citizen, and consequently we can then start putting information together using a modern internet-based protocol rather than our traditional just looking them up type methodology. Sadly, date of birth and name followed by zip code are still the most used systems in the NHS, and in some of our black and minority ethnic population high density areas, they simply don't work. Naming conventions are different. Date of birth may be approximated. I've got 5 minutes left. Wow, I'm even by my usual standards, that's bad. I apologize. I may use a tiny bit of your coffee break if you'll indulge me. Staff identity, again, every time somebody looks up a piece of information or enters a piece of information, I want them to leave their digital fingerprint attached to it with absolute clarity and certainty, and that's part of the trust agenda we need to work to. In turn, that means I need the tools to do so to be really easy for clinicians. You've been into bars, I've been into bars in which the staff in that bar can swap who's using the cash point instantly using usually magnetic tags or staff tags at once. But in our hospital sector, we ask people to sit and to log on, and that log on takes time, and then to get through to the individual piece of software they want takes even longer. This is ridiculous. We need to standardize medications. We have a national dictionary now for all medications and medical drugs. We have a dose syntax we finally worked out to agree between pharmacists, primary care physicians, secondary care physicians. That took a long time. That's now done. Dates and scheduling. Interestingly true of US vendors as well as UK vendors. We have international standards for dates and scheduling. If you order a plane ticket, it will be adopted by your phone, whether that's Microsoft, Android, Apple, or even RIM for the truly old. But do we have a dates and scheduling convention across the health service? Not yet. We need to. Clinical observations, basic pathology, and we use SNOMED CT for diagnostic codes. So our aim in X is standards and platforms where necessary to guarantee that interoperability, particularly around that identity piece. We have a routine backbone across the NHS called the spine that holds citizen and staff identities and does not allow information in or out without that assurance. But market-led digital innovation, as I mentioned to you before, the market does better at this than we do. We will drive it. We will aim for innovation. But I also want to make that fair. We have clinicians sitting in their own back rooms with a couple of coders deriving what they believe to be a fantastic app that will solve the world. Well, there are 8 or 10 sets of those doing it identically, and somebody else has already solved the problem. We need greater transparency to avoid wasted effort. And then developing local capability. It's all very well having excellence at the center, and I hope we have, but we need every individual organization to understand how they adopt technology. You've seen the class survey work here from the US, that the best, most innovative centers in the US use Cerner and Epic, and the least effective centers use Cerner and Epic. So it isn't the software system, it's the way you implement it, it's the way you engage with your staff, it's the way you make it work for your patients that counts. These are probably best read in the comfort of your own office, but these are the standards we're using: SNOMED CT, DMD, ICD-10 for disease classification, HS7. I have 2 minutes to get through a number of slides, and I want to use my summary slide because I quite like it, if it's the same one I remember. What have we done so far? Significant amounts of work to try and join together the critical handovers of care from the family practitioner to the hospital and back again is the most important point to get that exchange, because we don't have vertical stacks by insurer or by EMR in the UK. They are using different systems, and if we can join those together, we solve most of our problems. So hence Care Connect, Transfers of Care, GP Connect, all at that point. The national number for identification, SNOMED as our coding, and I mentioned DMND for Dictionary of Medicines and Devices to make sure that works. Medication standards, I think, are probably the thin end of the wedge that drives all standards. They are absolutely underpinning to safety. I have yet to meet a single clinician who argues against having medication standards for interoperability anywhere, and they touch every system of care we have throughout the entire health service. So that's the piece on making medicine safer. I'm going to run over time just by a tiny bit. Be indulgent. But in the UK, and by the way, this is a figure I'm proud of, we spend 17.4 billion on medications. I know your spending dwarfs ours. Indeed, as I understand it, US spending on medication dwarfs our spending on healthcare, which is quite interesting. I don't entirely understand the differential pricing, and I know that we are looking forward to an enormous trade deal with the US, so I continue to be slightly nervous of your medication pricing relative to ours. But it represents some 10% of our entire expenditure on healthcare. And we could pull out between 1 and 2 billion tomorrow if we had standard interoperability of messages that meant we deduplicated prescribing, that we assured people of using the best medication for a given indication, and that we used biosimilars, particularly in the field of arthritis and other medications. That would save us between 1 to 2 billion straight away. That is phenomenal sum to go for. So our aim: improve safety, reduce waste, absolutely to improve healthcare, and to support the citizen to better understand the medicines they've been prescribed. They come to me in the emergency department, they drop a carrier bag onto the desk, and it becomes rapidly clear they have almost no idea what's in it, but take a random handful morning and evening. I've talked about this. This is our dose syntax. Pharmacists, primary care physicians, and hospital clinicians talk about the same medication in really different ways. And yet in my field of emergency medicine, we use shorthands for much of this, which may be, to one of my colleagues, could we please organise 250 of Fluclox to the patient in bed 7? They will fill in a whole series of gaps as to the route, the exact doses and all the rest to that. And how do we manage to do it? Because at the moment, some of our systems demand that the clinician, if they want to prescribe that medication electronically, complete a drop-down that fulfills every requirement for everyone who's ever had an interest in medicines. And 20 drop-downs later, they've forgotten why they were prescribing the medicine in the first place. I've talked about these for the demographic service to link everything together. One, across the whole nation, it's really effective. A national record locator. At the moment, that is in its early stages. If we get that metadata right, that becomes really powerful with permission of the citizen and for their direct care. An event management service. Forgive me for a moment. I know I'm in such trouble on timing, but yeah, I flew over here. It's worth it. National event management is a really interesting exercise for safeguarding our most vulnerable. It is only through this sort of digital technology I think we can do it, because it's spotting events that haven't happened. The child who hasn't been vaccinated or who hasn't had a health check but should have done. The patient with learning disabilities who's meant to be on an annual review but hasn't turned up. So our event management system is designed to help spot people who've either accidentally missed care or who are being deliberately withheld from care. And sadly, that happens as much here as it does in the UK. It's a really powerful tool, and it means when they do crop up anywhere within the health service, those messages are immediately alerted to the clinician seeing them that there's more they need to do. Identity, I mentioned, terminology and spine. In order to, with login, by the way, secure and confidential login system for the citizen, this is the assurance. So we're saying, as you are in the US, anyone can build an app, but we are mandating the use of a single national login system to absolutely securely identify the citizen, and only when you've passed through that do we allow your personal identifiable information into that app, onto your phone, whatever else it may be. I won't dwell on it, but we have 2 neighbouring UK hospitals that have managed to fully interoperate Epic and Cerner. They are very pleased with themselves, just so you know. It took quite a lot of effort, but they've done it. You should steal it if you're trying to do that anywhere here. What's next? Please grab it and read it, but we have our work cut out with trying to work for international standards, particularly as we bring in ICD-11. And when it comes to medications and pathology, we are all talking about the same pathology. We are all talking about the same basic observations and the same medications. We should, and that's why I'm here, work together to make sure we do agree a common set here, though we absolutely insist on metric units, just for information. We're scientists. I think 3 digs is probably enough. I should stop now. But because when we agree absolute commonality on these sets and then work with our vendor market, we stop individually asking them to make changes and we collectively save a huge amount of effort and energy. Thank you very much indeed. Do I have a minute or two for questions? I do have a minute or two for questions. Excellent. So there are standing microphones there and there. There are walking microphones for those who prefer it. Are there any questions?
You
Please
may have
introduce
heard,
yourself.
Adrian Gropper, Patient Privacy Rights. You may have heard about talk here of single payer or not. How would patient ID, for example, and other aspects of what you're doing have to work the same or differently if there wasn't a single payer system like you have?
No, I completely understand. Thank you. I'm actually coming at the single patient identity specifically from a safety perspective. So we run a risk of misidentifying people, or where we have correctly identified them, of not being able to pull through all of the health information that they wish us to see. And those are important qualifications to that. So what we're trying to ensure is that people are correctly identified at their point of need. We absolutely don't use biometrics to identify them. I just want to be clear on that. There's a lot of discussion. We were talking to India about this who do. We don't. But our intention is to correctly identify someone at their point of need and to be able to use that identity to link together all of their health information that they wish us to bring together. And I hope that improves their safety. So I think there's that case separately from a case about payment and business intelligence and other things where it is very helpful to link. Just on that one, because I think it is worth mentioning from a privacy perspective, we have a national platform to de-identify people's health data, to pseudonymize it and put a independent identity onto it that cannot be traced back, and then link it for the purposes of research and business intelligence. And that's a national platform we built to cover all of health data. We do allow people to opt out of it, but where our opt-out rate is running at about 1.5%. One over there.
Hi, Carmen Smiley, ONC. So a little bit of Mythbusters, maybe. I read that NHS has spent 20 billion English pounds on implementing your unique patient identifier, and you still have duplicates. Is any part of that story true?
Well, we haven't spent that much. Let's be clear. Did you say 20 billion?
That's what I've
No,
read.
no. So our total expenditure on healthcare IT to date is about 14 billion on like everything, the EMRs and all of it, including Epic, for crying out loud. I'm not going to pick on them, okay? Otherwise, I have to pick on Cerner and the grey screen of death. But let's not. I've used all of these systems in time. So we do have a unique identifier. Yes, it does contain duplicates, and we have an interesting challenge. It contains, just to be defensive for a second, it is the best identifier of our whole population of any that we have available to us, including the equivalent of Social Security and passports and taxation, interestingly, because there's sort of no need to game it. There's no incentive to either the citizen or to the system to game it. But when people come in unconscious, when we can't identify them, when English isn't a first language or they're frankly too drunk to tell us, we sometimes get that wrong. We do have a reconciliation process that gets that right.
Understood. Thank you.
Please.
Good morning. My name is Shelley Spiro. I'm the Executive Director of the Pharmacy HIT Collaborative.
Okay.
Collaborative formed by the majority of the national professional associations here in the United States. And on behalf of the pharmacy profession, thank you for recognizing pharmacists and mentioning pharmacists and the importance of medication and managing medications through using health IT to take care of that. My question is, and we're focused on clinical services that pharmacists provide and making sure we can document that information in an interoperable way and work very closely with the standards development organizations, NCPDP, the National Council for Prescription Drug Programs, and also HL7 and the Fire Resources. Is DHS doing that in the UK? Are you moving to documenting more clinical information that pharmacists can provide to help with the care of our patients?
So thank you. Within the hospital sector, the answer is yes today. Within the community sector, it isn't, but it will be. So we have a specific program that is in the process of kicking off as we speak. Bear in mind, NHSX was formed formally on the 1st of July, so give us a moment to get ourselves going. But there is a specific program for pharmacists, optometrists, dentists, physiotherapists and others, community practitioners providing frontline community healthcare services where the citizen would like them to be able to see the record, would like them to be able to enter information into the record, would like them to be able to accept referrals from elsewhere in the system. So we refer people to physio, we refer people to their pharmacy, particularly for medication checks and follow-ups. Allow those practitioners to make referrals. And that doesn't happen at the moment. So allow pharmacists to go, this isn't working, I'm worried about side effects, whatever else it may be. I wish you to see your own clinician, I'm going to make you an appointment to do so. And lastly, to prescribe within the legal boundaries that sets up. And we do have pharmacy prescribers across the UK able to do that. So the answer to your question will be yes. We see them as frontline healthcare workers and they need to be recognized as such.
Well, we'd be glad to reach out and help in any way. Thank you very much.
Thank you. Sticking with the alternating themes.
Okay. Well, Keith Boone with Audacious Inquiry. So you mentioned earlier in your talk about how you'd been at this for a while and you had some great technology and not a lot of interoperability. I know when I started in this field more than a decade and a half ago, the NHS had been at this for quite some time already. So can you just tell the folks here how long the NHS has been at this challenge of trying to create interoperable EHRs and how many reboots you've had?
Gosh, the history lesson of national expenditure. But the National Programme for Information Technology, which was Tony Blair as our then Prime Minister, recognizing this was a major challenge, came up with the idea. The history relates to the back of a cab somewhere in London, scribbling it onto the back of an envelope. The cost turned out to be not quite right over time. I think it started at 2 billion and it ended up at 12. We did a lot with it. We bought a lot of healthcare systems. We didn't hard bake the interoperability in at that time. To have spent 12 billion on a project that was politically deemed not to have succeeded basically stopped innovation for a period. And we had about 5-6 years in which our mission was to act as a warning to others. I myself, I retreated to clinical practice in my emergency department for some 6 years. Actually, I got really bored doing that, so we rebuilt a section of the hospital, which I led, which was great fun, and changed the way we ran emergency care in London and other bits and pieces to keep myself busy. And then they said, come back, we're going to do it again. We're going to reboot. But this time, we're not buying systems. We're buying the infrastructure to enable interoperability. And we're working with local providers to buy the system that works best for them, because it is that implementation of the system that makes the difference between success and failure. And that's how we're running it now.
Good morning, Mark Savage with UC San Francisco Center for Digital Health Innovation. Thanks so much for being here. We are having conversations here about patient-generated health data, social determinants of health. You've talked a lot about systems exchanging information with systems. These are issues about patients contributing data from themselves into those systems. Can you tell us a little bit about how that's going?
So the aim is the personal health record, the citizen's view of their own health record will allow them to add information. That may be information they choose to add free text. That may be information that they're encouraged to add by an app. For example, those with mental health may be encouraged to add their mood on a basis to provide a longitudinal chart, which is incredibly helpful to both them and the clinician. Or it may be data added by wearables. And we're all familiar now that with both Fitbits and Apple Watch and others providing a one-lead ECG. The challenge becomes, what is the physician's responsibility to check data that has been added by the citizen themselves that may or may not contain an abnormality requiring action? So we have this at its biggest with that one-lead ECG for atrial fibrillation. If you come and get diagnosed by with atrial fibrillation that's causing significant disturbance to you in my emergency department, we are likely to start you on some sort of blood thinner. We are underdiagnosing that within the population. It's thought to be a significant cause of strokes. But we don't know what the effect will be. There is no research. If every time anybody's Apple Watch suggests that they've got a hint of atrial fibrillation, we slap you onto a blood thinner, how many strokes are we going to generate as a consequence of that? That research is live, that conversation is live now, and that ownership of the data rests with the citizen, but what responsibility we have to it is undecided. So I think this is a new health problem worldwide. I'm talking in Canada and Australia about exactly this issue, and I suspect we collectively will slowly start working out how to do it. But it's a really good question. Thank you.
Thank you.
Hi, Max from Federal Contractor. My question is around, not political question, but it is tailored towards patient care coordination and patient empowerment. What is your vision and roadmap for international interoperability? I know geographically, it's a part of the European Union, NHS. So you get a care from primary care in UK, in Scotland, and you can transfer to another country, like Germany or France, or you get a prescription prescribed at the point of care in UK, and you get filled somewhere else. So I know ONC and European Union did international interoperability projects in the past. Do you have any vision and roadmap given the geographic nature?
Yeah, gosh, thank you for that one. As you know, I am paid by our equivalent of federal government for my time, for which we have a clear prime ministerial commitment to leave the European Union on the 31st of October. Consequently, work on interoperating with our European colleagues and friends is not making huge progress at present. There has never, to be fair, there has never been a particular drive to interoperate at a European-wide level. There is clarity on the need to be able to identify citizens at a European-wide level to understand eligibility for care, and until the 31st of October, I have a card that entitles me to free care anywhere in Europe. No one's quite clear what happens on the 1st of November, but we will, I'm sure, work it out. I am so going to get sacked. But to answer the higher level challenge that you raised, there isn't a nation I've come across that isn't facing exactly the same interoperability challenges we're describing. We're off to Hong Kong in a little while to the Global Digital Health Partnership, 25 nations represented there. At the end of last year, I was a big international 9-nation conference with the Baltic states, Norway, Sweden, Iceland, Denmark, Estonia, Latvia, Lithuania, and colleagues, who are really digital nations, by the way. Estonia, one of the most digital nations on earth. They are small. They are 4 million people. That's like half of London. But on the other hand, wow, have they got this sorted for digital health and digital state provision. But even they have these same interoperability challenges. So our aim is, if we can work internationally, agree on the standards, FHIR, SNOMED, and others. And let's be clear, saying FHIR as if it's going to fix things, it simply doesn't. You've got to curate those standards, you've got to make them work, you've got to implement them in a way that's meaningful and allow that information to exchange in a way that successfully improves the patient's care. Otherwise, it's just semantics. Oh. Okay, thank you. I wasn't expecting that. Note for self. And in that journey, we are infinitely more powerful working internationally together to try and solve it than any one of us are on our own. So I hope that's helpful to you.
Thank you.
Please.
Good morning. My name is Tony Sheath. I'm with Point of Care Partners. It's a consulting company. So here we have a process that is called prior authorization, where insurance companies, authorize certain procedures, devices, medications prior to them being administered or provided to the patient. We're in it's a burdensome process, and we're in the process of trying to automate that to make it operate more efficiently. Just curious, does the UK have something similar to that? And have you made any progress in any sort of automation if you do?
So the short version is this is one of those areas in which our two healthcare systems are quite spectacularly different. So we don't. The concept of how what is agreed and how the money changes hands just sort of doesn't occur. The clinician prescribes whatever they wish or authorizes whatever they wish. We do have some real elements, though, where although we have a single payer market, we have commissioning groups. We have local community groups, by which I mean covering a population of sort of 500,000, who agree what care they're going to provide in that area and where the boundaries are. So we see some of this. And the second element is we have an organization called NICE, the National Institute of Clinical Excellence, who agree that medications, devices, new services potentially being offered offer value for money. And their value for money criteria are based on the concept of a quality adjusted life year. So something at the end of life, and we've had this, this has been really difficult, but the nastiest example I can give you is in cystic fibrosis, where I think this is equally true here. There's a cystic fibrosis drug available that does significantly prolong life, though not in huge numbers of years, but at a price that is frankly ridiculous. It's extremely profitable for its manufacturer, shall we say. That's been a subject of some scandal in the UK. And NICE simply cannot justify its use against the criteria, given that money could equally be spent on interventions that do make a difference. We have exceptions to it for research. We have exceptions to it for cancer, for some end-of-life conditions where the spending limits are changed. But we have assorted processes that try and help the clinician understand what's best. So I was mentioning biosimilars. We have a really strong drive here to generic medications and biosimilars in order to keep the bill down and make the money go further elsewhere. I hope that helps to some extent.
Thank you.
Good morning. Thank you.
Okay.
Jennifer Stoll with Ochin. Similar to the question that the last gentleman asked, looking at total cost of care and evaluating being able to get data down to the provider to be able to look at cost. Are you driving toward that, or is there something integrated in your system that you're thinking about? Thank you.
No, so it's a good question, and yes, we absolutely are. For those who are particularly interested in this, I would recommend a program, it's all online, called GIRFT, Getting It Right First Time. So this was pioneered by Professor Tony Biggs, an orthopedic surgeon, the most orthopedic surgeon of all orthopedic surgeons you've ever met, actually. Strong rugby history. Rugby is essentially American football without padding, played with more violence. Orthopedic surgeons love it. But what they showed is dramatic improvement by reducing variation, improvement in outcomes for patients, which is really interesting. Individual clinicians clinging to, I do it my own special way because it's better, turned out not to be true. That where you standardize on processes accepted as best practice, you improve outcomes. You also dramatically reduce costs and increase the total availability of care. So we've done a significant amount of work here. And when I say total outcomes, which I think was your question, including right up to what matters is the citizen independent in their own home, evaluating their movement from the joint replacement, whatever it may be, as being back to their original level of care. That's how it's evaluated, rather than being looked at from post-operative infections or any rather medical criteria. Total cost of care, total cost of re-enablement and mobility. And what we discovered is we reduce variation, we reduce cost, and we improve outcomes. Thank you all. very much indeed for listening.
Thank you very much, Simon. We are at that point. You'll see me jumping up and down now for the rest of the forum. We're going to be back in here at 11 for the current state of interoperability plenary. Please, I know we've got to shuffle everybody out and shuffle everybody back in. If you start to come in a little bit late, please try to just circle around the back, and we'll see you at 11. Thanks very much. Thank you very much for coming back. One other announcement, if you do tire from interoperability and you want to spice things up, there's a bachata conference here as well for Latin music. And so if you happen to wander into the wrong event, you'll know it. So when we break up into the tracks, and that's one other announcement, after this panel, we'll need everyone to help us help you clear out. We're going to split this room up into the constituent pieces for the various different track segments. So if you can help us logistically, we have to clear out of the main area as fast as possible after this panel so that we can get the track set up. Thanks for that announcement. And we are joined here by our illustrious panel led by the illustrious Elise Anthony, our Office of Policy Director. We're going to talk about the current state of interoperability. I'm going to do a quick introduction for all of the panelists so that they don't have to do that themselves, and then we will dive right into it. So first I have Morgan Honey from Coreo, the CEO. Morgan serves as the CEO of Coreo. It's one of the largest HIEs in the nation, serving Colorado, areas of Wyoming, and Kansas. Morgan helped lead the development of the State Office of eHealth Innovation within the Lieutenant Governor's Office and serves on the eHealth Commission working to provide oversight for the implementation of the State Health IT Roadmap. Patrick Getson, did I get that right? All right, awesome. Senior VP at Blue Cross Blue Shield, North Carolina, Chief Data and Analytics Officer, has over 20 years of experience in the health insurance industry, and in his role as SVP of Chief Data and Analytics Officer at Blue Cross North Carolina. Patrick focuses on data quality, stewardship, and governance, as well as analytics enablement for the company. Jim Barnett, Director of Strategic Intelligence and Analysis at AARP. As part of his role of the future casting team, Jim is responsible for identifying external forces and future trends most likely to impact AARP and its members. He is as an interesting fact, a former award-winning investigative reporter and editor for highly regarded regional newspapers, including the Raleigh News and Observer, the Portland Oregonian, if I got that correctly, and the Washington Post. And then we have Philip Parker, CEO of Coral Health, an experienced health professional in advising life science companies, provider organizations, and payers. He's the CEO of a company that offers a free app available on iOS and Android that allows patients to securely view and aggregate their health records from everywhere they've received care. And Coral Health is connected to several hundred leading health systems, along with the various spectrum of health IT developers that support those health systems. So, without further ado, just to keep us on time, very much, again, thanks to the panelists, and enjoy your time with Elise.
No pressure. So let me just start out by saying, what is this panel about, right? So what we're talking about today is the current state of interoperability. And as you guys have probably heard me say 1,000 times by now, we can't do it alone. So hearing what's happening on the field, whether it's from the innovation aspect to some of the challenges that exist, I think are important not only to ONC, but also to the landscape, because that's how we all learn. That's how we all hear about lessons learned and new opportunities, innovation, collaboration. All of that happens through sessions like these. So my hope is that I can be a vehicle to bring out some of that conversation and to hear from our wonderful panelists. So with that, I don't think there's much more introduction we need to do. So why don't we start with a down-the-line question to give kind of a landscape of what you guys see. So I would say in your particular positions, in your particular environments, with the stakeholders you work with, talk about the current state of interoperability, what you see.
Sure. So the way I see it is we've invested a tremendous amount of resources in laying the foundation for interoperability, but we have yet to get a lot of the value from that investment. So to kind of put it another way, one of the main debates we're having today is whether moving to EHRs has actually led to productivity increases and whether it's actually even been worth it. So we've made a tremendous amount, a large investment in digitizing the system, and yet we still haven't seen much of a return on that investment. But in terms of the encouraging signs, we've laid the foundation. We have Commonwealth, we have Care Quality, we have these organizations that are starting to be able to make data interoperable and get it to providers at the point of care. But at the same time, there's a tremendous amount of work ahead in terms of reducing the burden for physicians, not just sending data to them, but making it easy for them to filter and get the data they actually need so they can make use of the tremendous amount of information that we have available today.
So my perspective will be from the payer side, and we're really focused at Blue Cross North Carolina on our relationship with our strategic provider partners in North Carolina. So I'll kind of put that lens on there. It's fairly early in the journey for interoperability with providers today, payers and providers. When we exchange information with providers today, it's largely in the form of either canned reports or claims extracts that we send to them. It's not very frequent, largely monthly, sometimes even quarterly. So the information we're giving to the provider is actually not real time enough to be actionable by the provider. On the member side, it's even more limited. It's kind of access is gained through portal entry. It's usually around administration of policy. It's not about the member's health. I think there are a handful of things that we'd like to see with regards to interoperability that would advance us to a more mature state. The first is that the data that we're exchanging is not standardized. So we're creating custom data extracts for our providers. As a result, there's a lot of infrastructure cost that goes, labor cost that goes in with it. And oftentimes, even the data that we exchange is not understood well enough to be trusted. The second thing is we have to have interoperability, the data moving faster between the parties that are exchanging the data. And the reason we have to do that is because we need to get to a point where clinicians are getting information that they can use at the point of care delivery. That's the outcome we're looking for. I think the data quality is a third thing that we have to focus on. There are not really consistent processes for certifying data as high quality that you're going to exchange. If it's not trusted between data exchange partners, it won't be used effectively, and you'll put a lot of effort in and not get a lot of value out. And then the last piece maybe that we could focus on is clarifying the roles and responsibilities around who owns this data once it's been exchanged. So if I send claims data to a provider and I get clinical data back from that provider, what's appropriate for the use of that data at that point? Who's responsible for tracking consent authorizations in this world? So, and I know that you guys are working hard on policies, so we're really looking forward to what you're coming up with, but those are the types of things I think that we're looking for in order to make our provider partners more successful.
So it's probably a good thing that we're sitting next to each other because we have very different perspectives on some of those things. First off, I would say that I live in Denver. I'm visiting here in DC from the beautiful state of Colorado. And I can tell you indefinitely that the warmest day on the slopes is better than your conference rooms in DC. And it's absolutely freezing around here.
No argument there. Even under the lights, it is cold.
So I figured I would start out by throwing a few pros and cons out there. I think the pros are that we have some incredibly great minds and a lot of really great organizations working to solve this problem of interoperability. I think that our vendor partners have come a long way, and technology has come a long way to reduce the barrier of the technology related to interoperability. I think that the proliferation, the use of APIs is going to go a long way. That doesn't change the fact that in my organization we offer XDS.B, XCA, HL7 connections, CCD interfaces. I mean, the alphabet soup is nauseating, but APIs, I think, will reduce the burden of the technology associated with creating interoperability. I think one of the challenges in that same vein, though, is that too many times the solutions are being marketed as decision points, not complementary. So I think you don't have to, if you're working inside a health system, you shouldn't be forced to make a decision between Care Quality or Care Everywhere and Choreo. They're definitely complementary technologies, and as we think about the things that we want to do with interoperability, whether it's public health reporting, real-time alerting, population health analytics, there are certainly roles for query and response type of functionalities, but then there's a lot of use cases out there that are going to require different types of aggregate information and a different type of data set. That's where we stop. Yeah.
Great. So being from AARP, I'll bring the consumer perspective a bit here. What we see is a lot of infrastructure. We've been some nods to that, and there's a lot of money being invested, and that's great. We have systems talking to systems, and that's where it has to begin, of course. But ultimately, we see, right now, I would say the current state of interoperability is not great for consumers. What is happening, we see, is that the consumer is becoming the ultimate point of integration for all this stuff. And consumers, if they're the last mile, they're not ready for it yet. They're not educated for it yet. They have a lot of responsibilities will be put on them to figure things out that they're not ready to do yet. So they also need tools. There was some discussion this morning by Dr. Eccles about everybody's glued to their phones, but they don't want to go to the kiosk in the doctor's office. Well, there's reasons for that. So we need to make things that are more consumer friendly and more easier for them to use and to digest and to understand and to have agency as well with their records and their data. So I think right now I would say that the state of interoperability is really like trying to get kids to eat spinach. You can tell them it's good for them, but it may not be the first thing they want for dinner.
And just to build off of that point, something we've observed is just the tremendous amount of how patients really need someone helping them through that process, but how difficult it is today for any entity to help that patient through the process. So, I follow pretty closely the Citizen blog, and they just came out with a great scorecard of how hospitals are, whether or not hospitals are actually complying with the HIPAA right of access. So when you think about the tremendous amount of difficulty in even getting hospitals to comply with a law that's been around for over 20 years, that's a tremendous barrier when you're thinking about pushing that burden onto patients. There's very limited ability for anyone to help the patient through that journey, and patients are struggling even when they're doing it themselves.
Yeah, I didn't say it'd be easy.
So Phil, let me ask you a little bit about that. From your perspective as a developer, can you talk about some of the challenges that you see, whether it's authentication or any of those things that have probably come up in the process of kind of the development and the reaching out and engaging with those who actually have the data, at least initially. And then talk a little bit about maybe some of the things that you see that maybe we don't see in terms of the opportunities that might exist in that same space.
For sure. So I guess kind of my day-to-day, it's interesting, involves a lot of kind of interacting both with the EHR vendor to kind of get through their developer programs so that Coral Health is able to connect to the APIs that they have available. But then it's also going out to the provider organizations and getting authorized to be able to access their endpoints. And that's kind of it's an interesting back and forth where kind of there's no one, it's very dependent on the EHR vendor. So some organizations like Epic make it very easy to connect to their endpoints once you're approved. But then others like Cerner and many other EHR vendors, you have to get individual authorization from each provider organization before you're even allowed to help patients get their own records through these new FHIR APIs that are available. So it's a lot of kind of dialogue with those health systems just to kind of go through those steps. And then in terms of the patient side, one thing that really jumped out to me was a lot of patients just don't know all the different places they've received care. So it's not enough to just have these, even if I was connected to every single healthcare provider organization out there, patients don't know all the places they've received care. And it's really on app developers and providers to help them be like, you've received care here. These are the organizations we can help you get your data from. And that's, it's a challenge, but I think there's a lot of opportunity there when you think about the APIs becoming available on the claims side, where you could use that claims data to help direct to the patients instead of overwhelming them with a list of 1,000 healthcare organizations and having them try to search for which ones they visited. Why not use their claims data to help them filter that list? Okay, it looks like you've been to these places. We can help you get your records from those locations. So it's interesting. There's a lot of work coordinating between these different entities.
That's helpful. So Patrick, looking at from your perspective, and you said there's early stages of interoperability. The provider to payer landscape may be a little bit different. What are some of the things that you see as necessary to solve right away, that you're working on solving to address some of these issues?
Yeah, so we're like every payer in the country and every provider in the country that we're focused on triple aim of cost, quality, and experience. We've not solved that effectively. I won't go through all the numbers of how we've not really hit that bar, but I did want to tell you, from an affordability standpoint, that's one thing we're doing in North Carolina is tracking what North Carolina families are paying out of their pockets, percentage of household income that are going to premiums and out-of-pocket costs. And it's pretty sobering when you see how much healthcare costs today. And it's not just sobering from a point in time, but if you actually look at over a period of time, it degrades over time, and that's because healthcare premiums go up 6 to 8% a year, and salaries go up on average 2% a year. So we're at a really important time in the healthcare industry to try to solve this. Now, one strategic initiative, we were talking earlier, we have a new CEO, Dr. Patrick Conway, who used to run CMMI. And although we were doing work in how we pay our providers before Patrick came in, he really accelerated the idea of moving from a pay-for-volume perspective, or what's referred to as fee-for-service reimbursement, to paying for value, where providers are held responsible for the quality of the care they give, as well as the total cost of care and managing that. This is why it's really important from an interoperability perspective. We signed 5 of the largest systems in North Carolina last year to multi-year contracts that have significant upside and downside risk. A lot of the ACO type arrangements you see in the country are kind of evolution was they were all started with gain share deals, only upside risk. They started moving a little bit into some downside risk, and we're really trying to push it to significant downside risk. We think it's important because we think how you pay for these services matters. But in order for providers to be successful, we can't have them fail like what happened in the 90s where we pushed risk onto them and there were no tools available to actually manage the risk. In order for them to be successful, there's 3 really important things they have to have. One is high quality, accurate, and trusted data. The second is actionable insight that you can deliver. But the third, which is it's really the pipes of how to get them that information so that they, like I said before, they can actually deliver some different outcome at the point of care delivery. You can't hold a provider accountable for total cost of care and quality if you don't give them these 3 things. If a provider is held accountable for total cost of care, he needs to understand his attributed population, even when they're seeking care outside of the provider system. And that's why Blue Cross North Carolina is very excited about where CMS is going with these standards, and we're working hard to become fast adopters to them because we think it's critical to the strategic mission of what we're trying to deliver.
And Patrick and I were talking about this before we came out here. I'm a strong believer that alternative payment models are going to be critical to really advancing interoperability. I used to chair the payment reform committee for our state Medicaid agency, and a few years back when I did that, we started with a list of things that we would like to monitor in terms of a quality outcome approach. And I think that we started with something like 57 or 59 different data points that we were interested in saying, these are the things that we think we could measure that lead to quality. And by the time that we whittled down that list to the things that were actually available to monitor by the Medicaid agency, they were a list of 7 claims-based data points. And they were the traditional ones. They were, are you getting your asthma medications filled? Are you having an annual wellness visit? Those types of things. But as we can get into, if we can use payment reform and payment methodologies to push folks to use these types of interoperable tools so that we can better understand not only who my diabetics are, but who are my diabetics that are above 7 with their A1C or rising risk, or we've had some really interesting learnings with L&D reporting and how you get kids back into primary care. That's when it's leveraging payment reform to push those types of quality data elements that are really going to drive interoperability, in my opinion.
Morgan, on that point, you are doing amazing work in terms of Korea, and you work within Colorado and some outside as well, and you move a range of different types of data. You talked about the importance of data to the analytics, to making determinations and informing care. How do you handle the types of data, the different types of data that you move or you handle or you maintain? And you even move behavioral health data, I believe, as well. What is that landscape like? What are some of the privacy considerations that you've seen?
I mean, so as we talk about interoperability and to folks in the room, I would say, one of the biggest challenges that we have is this idea of consent and authorization and privacy policy. I mean, it is not a technology issue. You know, just moving 42 CFR Part 2, the privacy around that data flies directly in the face of what we're trying to do in response to the opioid epidemic. So we've really got to figure out how to align the privacy policy. I will tell you that when we start, and you know, everybody wants to talk about social determinants of health, we are somewhat going about that effort in a very different manner. We're very much engaged with our state agency partners, those who run TANF programs, SNAP program, WIC programs, to try and leverage the infrastructure that's been built at COREO, because that's what we build. We build infrastructure. We don't necessarily build tools. How do you engage with those state agencies that really have never been asked to share their data, either with one another or with external agencies? I think as we talk about social determinants of health in the context of healthcare, all of our FQHCs in Colorado have adopted the Prepare tool, and that's really great. From a healthcare perspective, we ask our clinicians and our caseworkers and our care managers to assess individuals for what their needs are, to try and get at those non-clinical sources of challenge. But then the question is, what do you do with that? So now that I know that Phil has housing insecurity, you know, as a clinician, am I charged with finding Phil a house? What we're doing in Colorado is trying to connect the folks in the state that are administering and providing those services with the folks in the healthcare industry who are assessing individuals for those services, or for those needs rather. And as you get into that realm whereby you have access, or you're trying to create access to WIC eligibility or benefits eligibility, whether or not you're in, you know, has mom had, there's this concept of a second-gen ACEs score. A mother with a high ACEs score or an ACEs score period is more than likely to have a child with an ACEs score as well. In Colorado, the Department of Public Health manages the ACEs registry. And so how do you rightfully disclose the fact that mom had an ACEs score to try and change the outcome of the child? Those are privacy policies that if you have been historically operating under HIPAA, we're sorely inadequately prepared to respond to those types of privacy challenges. We've got a program right now that we're working with the folks in Boulder County who have built a county-level workforce tool that connects into these different state databases to try and align benefits management with eligibility and different programmatic eligibility. Here's a shocker for you. Our state agencies don't know who's in their programs that's in the next state agency's program as well. So one of the projects that we've got going on right now that's really interesting is leveraging the infrastructure, again, back to Dr. Eccles' comments this morning, understanding who the people are. If you're in WIC, then you're automatically eligible for Medicaid based on benefits determination. We've balanced the WIC population up against our Medicaid population using our master patient index, again, recognizing all sorts of privacy issues, to try and understand who's eligible but not enrolled in WIC or Medicaid or vice versa. The outcome is going to be staggering. The enrollment that could be potentially in WIC because of Medicaid or Medicaid because of WIC is tremendous. And when you think about the fact of getting women, infants, and children nutritional benefits, I think we can all agree that that's really, really important. And so as we wander into this space of social determinants of health, we're going to encounter a vast array of privacy policy and governance issues that we've got to not only figure out from our own system levels, but across our state agencies, across our federal agency programs. And it's something that we're just really starting to scratch the surface on. But it's incredibly important work, and I would really encourage everyone to dust off your legal manuals and get ready for an inundation of different privacy policies. I'll close with a great example. When we first engaged the Colorado Department of Human Services, you know, we traditionally have been very used to working under HIPAA and under 42 CFR Part 2 and FERPA and the traditional healthcare policy privacy policies, but when we started engaging with human services, I think that they operate under something like 137 different privacy policies. Intermingled, inside child welfare is data that contains adoptive children, and adoptive children is some of the most protected data that you can gain access to. And so, how do you ensure, again, right, wrong, disclosure, access, authorization? It's wildly complex, and APIs are not the answer.
So that covers, I think, there's definitely much conversation to be had in terms of the privacy landscape, but I think hearing that you're recognizing that they exist and thinking about how to answer them goes to your point about things being complementary and how to kind of work through those and have those conversations collectively. I also heard in your answer, I tried to keep count, but I lost the number of different settings and types of patients that you engage with, which is quite impressive. Another segment, at ONC that we think about are how to think about the care continuum equally holistically. So not just for those of you who have been around for a while, meaningful use settings or promoting interoperability settings or settings that are paid through those programs, but also thinking about the larger spectrum. So we have a team that I lead that thinks about long-term post-acute care, that thinks about behavioral health, that thinks about pediatrics. And in fact, Congress has asked us to do a lot of work in the pediatric space, which we've also been thinking about and doing. So I'm turning that question to you, Jim, in terms of the segment that you work with, of senior citizens, and the environment of their use of technology. There's probably a lot of misconceptions about that. Can you talk a little bit about that and some of the opportunities that APIs can present for care in the senior citizen setting?
So we actually prefer the term older individuals, but but I think actually if you think about people who are older, we actually are a great proxy for not just folks who may feel disenfranchised because they don't want to use the technology, but also people who have a lot of data. And that's not just older people. I mean, when my daughter arrived early and she was 10 days old, she had tons of data, right? Because she was in the NICU. So I think, this is a place where the principles of universal design really apply. I think if we can, solve for the people who have lots of data in lots of places, we can solve a lot of problems for a lot of folks because we're all going to get there someday. I remember when I was, 30 years old, I had probably zero data. I was, invincible. And now I've got various specialists I go to, like a lot of folks do. So, so I think that's sort of the first thing I would think about. Beyond that, in terms of APIs, we discussed beforehand a little bit about the role of APIs, and they're great. I mean, it's a great way to share information. But one of the big challenges is that content just really doesn't make sense to consumers. Whether it's clinical data or claims data, it's really hard to interpret what it means, what do I need to do. So I think we need to have, I'm not just speaking about AARP, but I think broadly we need more work there. And then also, one of the things we do think about a lot in terms of tools is this notion of having a portable, high assurance identity credential. We really think that that's something that is going to really complement a lot of what we just heard about here. If people have an identity credential that they've chosen, that they know how to use, and then actually sets their terms of service and can port over a lot of really important information about them, that I think is going to make it easier in a lot of ways for folks to basically bring all this together and use it in a way where they have both agency and knowledge about what it means.
So in terms for older individuals, and I'm adjusting my terminology here, I like that. For older individuals, the consumer-centric aspect of interoperability, right? So interoperability truly is something that should happen behind the scenes, right? By the time it touches the consumer, it should hopefully be fluid, and that's where we're hoping to go, I think, all of us in terms of where things are. But the interoperability happening behind the scenes obviously has benefits for the consumer and making sure that there's a consumer-centric nature to that. What is AARP thinking about in that realm?
So we're doing a number of things. One is we're actually going really deep on policy. This is an area that is I'm not in our policy group, but our policy group is taking very seriously. We are looking at just all the implications of people having to control their data, but also just data being available just across such a wide array of sources. So that's one thing we're doing. We're also trying to be active. We're partnering out there We are now I should mention before I leave policy, if you're curious about it, aarp.org/health data. So it's a lot of what we're doing is out there. You can see that right there. We're also doing a lot of partnering. We recently joined the Caring Alliance. We think they've got a really nice vision for what interoperability should look like. And we would add to that as well with some notions around basic agency and also for education. We've also been participating. We've been out there in the market. We had a very small minimum viable product called AARP ID. It was not for healthcare, but we see that as something that could basically start broaching the toothbrush test. What's something you use a lot so that you can use it in those cases where it really matters. So it could ladder up to that level of assurance where a member or somebody could use it. And so we don't want to be the only folks out there doing that. We want to encourage others, but we would love it if the ecosystem would start adopting or could adopt those federated credentials in a much broader scale.
So one of the problems that I think that we're at right now, there are tons of vendors out there that make great apps that are related to specific conditions. We contract with almost all of them, it feels like. The problem is we can't have somebody, your comment about how it really should be behind the scenes. You really can't have somebody say, if it's a pregnancy app that I want to go get information on, I have to go into this particular app over here. And if it's diabetes, then I want to go over here. So there's a lot of talk in the industry now, it's early, about having a very consistent storefront that you would go into that has a consistent consumer experience, and you can pick the products out of the store that you'd like to have. But it's an important concept. I'm not saying that's the answer, but it's important. If you're going to actually have good data and good analytic insight to share with people, they have to want to use it. And so this experience piece is a part that has to be solved as well.
So I think, one of the things on the interoperability behind the scenes is something that I think about a lot in terms of the technology being in place so that information can move more seamlessly is really that concept. So and I always say this, I'm a patient, I'm a mom, right? So, and you see kind of where things fall apart, whether, I filled out the form online and by the time I get to the office, I have to fill it out again, even though I filled it out online. But anyway, we won't spend too much time on that. But needless to say, that's where there could be more interoperability happening behind the scenes. So that is a seamless for the patient, right? And that takes a lot. It takes a lot of collaboration and thinking about what are the best practices. So that takes me to kind of my next question, and it's open for everyone, is, talk about some of the best practices that you've seen or that you hope to see in the space of interoperability. Because again, it's not something that we as federal government can do alone. It's not something that stakeholders, I think, can do alone either. I think that having the right mix between the two and the innovation happening in the space is the best recipe for getting to that space of interoperability and seamless interoperability. So talk a little bit about some of those best practices that you're hoping to see or that you're already seeing.
So I think one really interesting example, both in terms of the positive side as well as, unfortunately, the negative side, is actually how PillPack was using data from SureScripts, right? So you might have seen that in the news that recently SureScripts cut off PillPack's access to prescription data. What PillPack was doing with that data was essentially getting consent from their new patients to be able to pull in actually most of their prescription data. And what they were able to do with that was essentially do the work behind the scenes to help figure out, what medications the patient's already taking so they can appropriately then mail them that set of medications. So what they were able to do there was leverage existing data, already heavily consolidated because of SureScripts' kind of fairly dominant position in the prescribing market, to leverage that data and make a more seamless consumer experience. Consumers are not going through the prescribing data there and trying to figure out, I took this one. No, that data is already flowing to a service that's helping them use that data to have a more seamless experience and a more accurate experience. They're not missing medications or getting the wrong medication. So I think that's really where I'd like to see things go. First off, leveraging data that we already have today, making it more accessible to patients so they can figure out what services they want to permission to use that data. But then also expanding other data types, so making it easier to get your lab data consolidated from LabCorp and Quest that dominate the lab market, and then easier to get your data from all of the providers that you've seen. And there's a tremendous amount of challenges around kind of the current credentialing, getting your patient portal credentials, trying to sign into 13 different EHRs. So that's probably the hardest one, but you have a lot of low-hanging fruit in terms of prescribing data, lab results, where there's a lot of value patients could be getting today.
I'll give kind of the same example of that where it's kind of limited to start with, but there's a lot of hope. I don't know how many of you are familiar with Verily's Project Baseline, but we're working, Blue Cross North Carolina is working with Verily on this project that's supposed to actually baseline the health of America. 10,000 people, they're setting the baseline, they're going to track it over 4 years and see how health moves for the U.S. It's a pretty ambitious study. And our CEO, when I said, hey, we're going to work with Verily on this, he said, hey, you know, it'd really be fun is if you're part of the study. And I was like, oh, okay. So I signed up for the study. And it's the first clinical trial I've actually been through. But there's a couple of things that are really interesting about it, I think. One is that I'm getting health information that I've never gotten before. And once you get that information, I really believe that that's information every American should have on their own health. Every person should have, every woman, man, and child. So that's kind of the hope piece of it. The hard part of it is that the information I'm getting, it's not super user-friendly, and this is coming from Verily, who's, you know, funded by Google and Alphabet, one of the most powerful companies in the world. I get ranges on what my health looks like on certain metrics, but then I have to go look it up on Google myself to figure out what those ranges mean. You really need to get to a place where it's easily clickable, I think, to get more information and get more insight into it. So it's really cool what they're doing, but I think there's a lot of area for improvement to improve that experience and improve the insight.
Any other thoughts?
Sure. I think what I would say is, not being a health expert, health data is everywhere now. So, you know, and again, HIPAA notwithstanding, you know, there is so much data being collected about everything we do, about, you know, how we type in a computer, how we breathe, you know, how we walk around our house, that I think we, in terms of best practices, I think we need to pay attention to the broader debate going on in our society right now. There's a lot of, you know, just read the newspapers, you know, with all the kerfuffle about Facebook and other places that gather data about us. This is data that is being used to set insurance rates in some cases. And, you know, New York just recently said, no, you can't do that, but that's a debate we're having right now too. So I would just encourage everybody here to not think about health data in a vacuum or as a special area. In terms of best practices, obviously more transparency, accountability. I think this is a great time for this industry to think about what those best practices are, because if you don't develop them and do them voluntarily, we're going to see a lot more regulation. In fact, that may be on the way anyhow. But I think it behooves folks in this room to get ahead of that, is what I would say.
Any thoughts, Morgan?
I think it comes down to people, process, and technology. No one thing is going to solve all of these problems. And I can give you a great example. I will channel my stakeholders in Colorado. The role that the HIE plays is really that of the last mile. And so as you think about the hospital that's in Cheyenne Wells, many of you think about Colorado, you think about the mountains and you think about the ski resorts, but the vast majority of our state is actually very rural and frontier. And so I think some of the technology efforts and some of the policy in particular continue to disenfranchise some of our lower resource rural communities. And so who is going to go out to Cheyenne Wells and help them adopt this technology? Who's going to train their staff on how to use it? Who's going to develop the process to change the workflows from a paper-based system or a manual referral system into something more efficient and effective? I think those are the questions that we need to ask. It's not just a technology solution. We have to bundle that with process improvement and the people to do the work.
I have one comment.
Yeah.
So I think that our industry, the payer side, has really spent a lot of time in protecting the information that we have, and part of it's because we're very nervous about the sensitivity of the information and security breaches around that. But if you think about what the world should look like in the future, it should be a free data exchange. This data should be used for many other things than it's being used for today. There's a lot of real value that can happen. So it's not just payer-provider or provider-member, but third-party researchers should have access to this data as well. Now, that's the glass is half full. what I would say is that policy really matters when it comes to this, because your comment actually made me think. Back in the day, I used to be an actuary. I don't claim that all the time now, but before I ran data and analytics, I used to be an actuary. And you can do a lot with the data that you shouldn't do when it comes to underwriting. And so policy really matters, and we got to make sure the policy keeps pace with the technology.
I think on that policy point, I think just from my own perspective, a lot of the movement that I've seen has been driven by ONC, for example. We're already seeing, not really compliant, organizations not being compliant with patient right of access. So I'd say like kind of the default is guard this data, and it's really been the government historically that's been mandating how data has to be opened up to patients, or right now through TEFCA for the sharing among health information networks. So traditionally, over the last 10 years, it's really been the government at the forefront. What I'm hoping to see is enough of a foundation being kind of established where now there are business models around helping the consumer make sense of their health, business models around helping the consumer, maybe they want to participate in a study, maybe they want to be part of a trial but not, go to that site. So to the extent that the government's able to lay a foundation for an ecosystem that actually is patient-centric, I think that's the key, and I think we're moving towards that, and I could see the industry accelerating really quickly once that actually happens, because then you don't have to guess as to what rule we can do. The industry can start moving on its own.
Yeah, and I did not tell him to say that, but
No.
I absolutely agree. In terms of our perspective, we always try to find the right balance of what that foundation should look like. The 2,000 plus comments and submissions that we got are helpful in us doing that on the rule, for example, which covers things like information blocking, what certified health IT developers have to have in place, including quote unquote without special effort APIs. But having that right foundation, our hope is that it then creates an environment where information can move appropriately with the right privacy and the right security protections attached to it. So we're moving in that direction, and thanks to all of the input that you've provided, we'll get there. So that's the exciting part, I think, for me in my day-to-day when I go to work, because of course I'm a policy wonk, so you'll never hear me say policy does not matter. It always matters. But every day we go to work and my team goes to work, that's what we are focused on. We're focusing on trying to provide that right foundation. So I think that's a wonderful opportunity for us to now turn it over to the audience and to see if they have questions for our panelists in terms of what they want to see or any questions about some of the experiences that they've had in the field. So we'll go left, right. So we'll start my left. We'll start over here.
Hi there, my name is Chetan Sarabu. I'm a pediatrician. I've also been a pediatric patient, and wanted to thank you, Elise and Morgan. I think both of you have touched a little bit upon some of the unique challenges in pediatric and adolescent populations. As we have all these great advancements in digital health and open access, APIs, interoperability, adolescents have been the most left behind by this digital transformation because we have not been able to properly manage information segmentation of sensitive information and differential access between adolescents and parents. In the physical world, as a pediatrician, I can have parents step out of the room, but in the digital world, we don't have that equivalent. And so I wanted to ask you specifically, Elise, and if everyone else wanted to weigh in, before the final rule is proposed, what steps will the ONC take to ensure that adolescent confidentiality is protected and properly supported in this new era of healthcare information?
Well, I think part of it was for me, so I'll just answer a little bit in terms of in our proposed rule, and well, let me start with Cures Act. In the 21st Century Cures Act, Congress asked us to think specifically about the pediatric setting. What are the needs to support, and how health IT can be helpful for that particular setting? And what we started by was, hearing from stakeholders in that landscape. But in our proposed rule, we included several things. Some things that would be available from a certification criteria aspect to support the needs of pediatric settings, and one of the things that we proposed was an updated standard for data segmentation for privacy, which would allow for segmentation of data not just at the document level, but further down at the data element level. So we're looking at the comments that we received in that environment as well. But we're also looking at what resources could be helpful to pediatric providers. And that's something that what we see from the comments will help inform so that we can think about situations like you've noted, but also in terms of the actual technical components that are necessary for pediatric settings. So it's two sides of that coin in terms of what we're looking at. So more to come on that as we go through the comments. But let me open it up to the panel.
I hear an identity problem again too, and this basically our analog to that is caregivers. You know, caregivers have a relationship with, you know, usually it's an older parent, but those relationships aren't necessarily clearly established, you know, for digital means. So, you know, you could be a spouse, you can be a child, you can be a power of attorney, you can be a ward of some other sort, but those things have to be figured out in terms of the relationship on a digital level. So it's a huge issue, but it's one that we're really focused on in terms of how do we help caregivers.
I think part of the big challenge there too, whether it's children or caregivers, is that you probably, when we think about cost and utilization and care management, those folks, the challenge is probably exacerbated because they're the ones with more problems. And you know, one of my staff members, schizophrenic uncles, comes to mind. He's homeless and has major mental health issues, and so needs a lot of team around him, and those data sharing and access issues are you know, compounding his challenges of navigating the system.
I would add to that, just there is the potential, especially in the caregiver setting. For example, my father has access to my grandfather's records. We're essentially kind of bootlegging it, where, you know, he gets portal access just by knowing my grandfather's credentials, and then he's able to download the results and kind of do that for all organizations. To the extent that you build out solutions that are helping a patient get access to their own records, you can actually kind of reuse similar infrastructure as long as that, you know, my grandfather, for example, is comfortable sharing, which he probably would be in that kind of caregiver relationship. So that, I think that kind of highlights to some extent where the patient is able to kind of decide, you know, this person needs access to my data. And it's harder to some extent for, you know, a health information network to make that decision. And they might not be the right entity to really decide that consent management.
I'm keeping track of time, and we're doing pretty well, I think. Okay. All right. Not as well as I thought, but we can take some. We do have some time for some more questions, so let's go over here.
Thank you, Elise. John Kansky, Indiana Health Information Exchange. I have two distinct comments that I'll try to keep them brief, and would be interested in feedback on either of them. It's a panel on the current state of interoperability, but at times it sounded to me like it was a panel on the lowest common denominator of interoperability. I agree with Morgan's statements that the most effective and efficient interoperability is going to be achieved when we get HIEs, EHR capabilities, and national networks working together. And there are significant markets and states in the country where some of the things that you described as current state, as future state, have been current state 5 years ago. So I just wanted to make that point. The other thing that I heard was that, and I violently agree, that patients should have better access to their data. I was encouraged with the UK's approach. Seems to have a very balanced approach to improving patient access to data and improving interoperability of the system of healthcare. And I think we need to be concerned to keep that balance and work on both channels to lead to the best interoperability. Thank you.
All right, we'll keep going.
Good morning. My name is Jenny Harvell. I work in Washington State and the Medicaid Agency. And I really appreciated your comment about health information exchange needing to be complementary, and following up on the last gentleman's comment about the multiple methods of health information exchange. In Washington, we have a state health information exchange. We have a growing number of regional exchanges and providers that are exchanging information in a variety of ways. And your comment about the multiple privacy policies, whether it's HIPAA, 42 CFR, 137 privacy policies for social service agencies, I think is particularly challenging. And I'm wondering if you or payer, ONC, can talk about how in an environment where there are multiple exchanges, as a policymaker, we can be aware of, more informed of, and supportive of these multiple and nuanced privacy policies.
Sure. I mean, there's a tremendous effort in Colorado to find, ironically, common agreement among how we interpret just the basic privacy policy like HIPAA. You might be surprised to know that public health and Medicaid may not interpret HIPAA the same way. I would point to the SHIG in California. It's not a rule, but it's legislatively adopted guidance on how California agencies are interpreting different privacy laws. I think that that's the model that I think we should all strive toward. Generally, I would say talk about it. It's kind of shocking to me how little communication happens around these issues, and it boils up into the Attorney General's office and becomes a big legal matter, when I think a lot of times it comes down to sitting down around a table, having a discussion about what is it that we're trying to do and why and who's going to be impacted, and having just a frank conversation about, you know, we use the vernacular trying to get to yes, right? It's very easy to say why we can't. It's not always easy to say why we can. And I think if we operate from that perspective, then maybe we'll start making some progress. But there are some areas around the country where this work is being done. The SHIG is the thing that I would hold out there if you're not familiar with it. Dan, I'm looking at State Health Information Guidance. I think that's what it stands for. SHIG. It's one of my favorite acronyms out there.
I'm going to try to pick us up so we can answer a couple more. Two more. Two more? All right.
Okay, thanks, Elise. My name is Walter Sujansky. I head up a consulting firm that focuses on clinical data integration and interoperability. Yesterday here I was involved in a workshop that was addressing, measuring, assessing the state of interoperability standards. And so I have a specific question about that, probably addressed to Philip most. And that is with regards to the FHIR APIs that your organization is working with across a number of different vendors. How would you assess the level of standardization across vendors with those FHIR APIs? To the degree that there are limitations in the standardization, how does that impact your organization and what you're trying to do? And what improvements to that standardization would you like to see, if any, that would help you do, and other app developers fully leverage the potential of FHIR APIs?
Yeah, great question. So I guess at a high level, I would say fairly good standardization across at least the major vendors that we've worked with so far. Unfortunately, some organizations still do have their own proprietary APIs, and they're not even using the FHIR standard. So that is problematic. But in terms of Epic, Cerner, and kind of the larger vendors, we have seen pretty good standardization. I would say the primary challenge is more around actually just getting access to those APIs, and also, and that kind of ties into awareness. Just because patients haven't been, you know, very kind of brought into the fold in terms of participating in getting access to their data, there's very low awareness that they have this ability to get access to their data. So there's a large kind of there's a big gap there where patients aren't asking for this yet because they don't know about it, and then and that makes it very difficult for app developers to get access to that. So I'd say it's less a standardization problem, but kind of an awareness problem. And then on top of that, authentication problem, where essentially you have all these portal accounts. You don't remember your passwords. You don't remember where you've been. So there's a tremendous amount of work just in terms of helping patients in that aspect. So I think there's things are moving quickly, but there's a lot of work still ahead there.
And our last question.
Made it time. Thank you for the opportunity to be here. My name is Pam Schweitzer. I'm retired U.S. Public Health Service, and I'm also a pharmacist. So I'm working, or I'm very interested now in rural health, and I know you alluded to a little bit in Colorado, but I'm really interested in the focus areas. You're focusing on addressing interoperability in rural communities, especially when you hear about elders and having just improving health and some of the limitations they have, not having access to the same things that they do in urban communities. Any focused efforts?
So I moved to Colorado to run an FQHC that was based out of Lyman. If you've ever driven to Colorado, you've probably stopped at McDonald's in Lyman. It's the highest grossing McDonald's in the United States. It's very challenging. I mean, rural healthcare is probably the hardest thing that you can possibly do. I'm convinced of it, whether it's provider recruiting or technology or even finding IT directors. It's a concerted effort. So we're working with our Office of Rural Health in the state of Colorado. Our state HIT roadmap specifically calls out supporting rural communities. At the end of the day, it's a cost and resources challenge. You know, my personal experience is that finding IT people in general in rural communities is very challenging. Finding IT people who understand health IT is very complex. Most of those folks, you know, navigate generally to urban areas. So I think that we've got to figure out a way to provide the necessary infrastructure. Many times that's simply broadband access. We've got to find a way to provide workforce support, whether that's, you know, reaching down into the high schools and trying to get kids trained early and keeping them in the communities. And then we've got to figure out, and again, I think this is where the APIs will come in great reprieve. We've got to find technological solutions that aren't the cost of what some of the vendors are charging right now to provide interoperability. And APIs, I think, will go a long way, but it's, unfortunately for rural communities, there's no easy button on that. At the end of the day, it's going to be dedicating resources to trying to bring them up to speed. And again, back in Colorado, the vast majority of our landscape is very rural. And it's very expensive to drop broadband in the mountains. And so, again, innovation and different types of technology hopefully will go a long way in trying to solve some of those problems.
So we have, is this on? We have very many rural communities in North Carolina as well, and I agree with everything you've said. We try to focus as well on independent physician practices in rural communities because they don't have the resources as well that a Duke health system or a UNC health system might have. So it's patchwork, how that's supported today. You know, our company gives money, other companies give money to try to help that along because we think the mission is strong. But I do agree that we need to get to scalable solutions for this that are lower cost so that it actually can be wider adopted.
Well, I think on that note of the importance of innovation and the scalability, those are all important concepts in what we're trying to accomplish here. I just want to thank our panel for an amazing discussion. I think, you know, perspectives are so important to policy. So it was a wonderful opportunity for me to sit here and to hear your perspectives and what you're seeing, and I think also for those in the audience as well. So join me, everyone, in thanking our panel.
Lunch. We'll clear out of here. These rooms will be set up for the tracks. You'll spend the next 24 hours with all of your new fast friends at your various tracks. And then we'll be back again tomorrow afternoon in the full plenary session for more keynotes, future state of interoperability, a spotlight panel from our colleagues in the Netherlands. And please, as you go through the tracks, the evaluation team has various different evaluations for the content sessions. If you could take some time to fill those out, we'd very much appreciate it. And enjoy your lunch. Be back at 1. Thank you.